Hi, everyone. Welcome to the Center for Ethics and Human Values Conversations about Research Ethics, CARE. It's a monthly panel, and today we're going to be talking about inclusive recruitment practices in research and addressing research mistrust experiences by historically exploited and excluded communities. My name is Deena Howard. I'm an assistant professor in the Center for Bioethics in the College of Medicine and also in the philosophy department. And I'm so excited to have this distinguished panel today. Adequate representation of diverse populations in research is a moral imperative, and it's a matter of social justice, it's a matter of scientific integrity, and also of engendering public trust. While people generally agree about the importance of adequate representation in theory, this doesn't always translate into our research practices. And so our panel today is going to bring really distinctive perspectives on the how-to when it comes to equitable recruitment and enrollment practices, and the ethical challenges that arise when we are working with populations and communities that have been historically excluded or mistreated in the name of research. I'm delighted to have as our external panelists, Amy Knopf, who is Associate Professor of Community and Health Systems at Indiana University School of Nursing. Dr. Knopf has an ongoing research program on equitable recruiting practices. She's focused on, in particular, on recruitment of adolescent research, as well as research mistrust. And she was recently appointed to the NASEM committee to improve the under-enrollment of women and racial and ethnic minorities in clinical trials. So Amy is going to be speaking first to sort of frame the issues, give us a sense about what the challenges are and how you've been thinking about it. And then we're going to hear from Dr. Shamika Thomas, who is the Provost Fellow in Bioethics, Race, Health, and Equity. Sorry. And she's in the Center for Bioethics in the Department of Biomedical Education and Anatomy at the College of Medicine. Dr. Thomas is a medical sociologist and a reproductive health equity scientist who comes to OSU after a postdoctoral fellowship at the NIH and in the Health Disparities Unit. And Dr. Thomas's work focuses on patient perceptions of non-invasive prenatal testing among Black women with genetic conditions such as sickle cell, both in the United States, but also in Ghana. And then after that, we will have Dr. Chisolm, who is the director of the Center for Child Health Equity and Outcomes Research at the Wexner Research Institute at Nationwide Children's Hospital. Dr. Chisolm is also the Vice President of Health Services Research and is a professor of pediatrics at OSU. Dr. Chisolm is a health services epidemiologist whose research is focused on measuring and improving the effectiveness, efficiency, and equity of pediatric healthcare. And she's an institutional leader at Nationwide and at OSU in improving equitable research practices across the campus. And I'm really delighted to have both Dr. Thomas and Dr. Chisolm to be here today. We'll start with Shamika. You'll sort of present your own thinking about this, the challenges you face, and how you've been sort of thinking about it. And then Deena, you can go next. And then I have some preset questions to get the ball rolling for the conversation. But then finally, we will definitely have time the last 25 minutes or so to just have questions from the audience. So if you see at the bottom of your screen, there is a Q&A sort of logo. Throughout the discussion, please feel free to start asking questions, and we'll definitely get to those near the end of the session. All right. Thank you so much, everyone, for coming. Without further ado, let's let Amy kick it off.
All right, thank you so much. I'm really honored to be here, and I'm going to talk quickly because I would really look forward to hearing from my colleagues and co-panelists. So I'm going to just share my screen. Okay, can you see that okay? Okay, perfect. Yes. So I'm an associate professor at Indiana University. And whenever I start a talk, I really like to acknowledge my privilege and my positionality. So I'm here today to talk about ethical and representative recruitment and engagement. And I do that as a white cisgender queer woman with a lot of social privilege. I really like this model of thinking about the ways that our intersectional privileges sort of move us toward the center of an academic career. And I am someone who sits very close to the center. And I just want to say that I don't have all the answers. I don't do this work perfectly, but I approach it with humility. And I really look forward to hearing from my colleagues and from you, and learning from you as well. So I was asked to just give a little bit about my background and why I came to an interest in these issues. So like Shamika, I also started my career at the NIH. So as soon as I finished nursing school, I'm a nurse by training, I should have said that. When I finished nursing school a very long time ago, my first job was at the NIH Clinical Center, where I administered phase 2 oncology drugs and other therapies for people with cancer. And I lived in Washington, D.C. at the time, and it took me a while, which is a commentary on, all the things that I needed to learn as a white woman, to realize that, as I moved from my neighborhood all the way to Bethesda, Maryland, it's very clearly increasing privilege and socioeconomic status. And within the hospital, all of my patients in the surgical oncology unit had very high socioeconomic status, and most were white. And I really started to notice that the people who were participating in research had tremendous privilege. Which you sort of had to be able to fly across the world or the country to, spend weeks at a time at the hospital receiving these therapies. But I just noticed the level of resources available at the NIH Clinical Center relative to what was happening at the time in Washington, D.C. This was in the early aughts, and the city was really hit hard by the HIV epidemic. HIV prevalence in general in DC as the whole was around 3%, which is a generalized epidemic in the population. But in some wards of the city, prevalence was closer to 8%. So a lot of people were experiencing preventable illness. And so I left my job at NIH and started working at a medical home for adults who were experiencing homelessness in Washington. The clinic was about less than a mile from the nation's capital, from the Capitol building, but it couldn't have been more different than the experience at NIH. We spent probably half of our days just on the phone fighting for our patients to get the care that they needed and deserved. It was really a transformative experience for me as a nurse and as someone interested in public health, to watch, generations of the same family suffering from the same illnesses that were totally preventable. And also just to see how difficult it was for people who were experiencing homelessness and other, life circumstances that they really could not control, have such a significant impact on their health. And so I went back to school to get a master's degree in public health and really look at what at that time we called upstream factors, but now we're talking about social determinants of health. I have developed a somewhat stepwise research program that really moved from HIV prevention in adolescents, particularly in rural Western Kenya, where I studied social network analysis and the sexual network structure and effects on HIV transmission. And during that time, biomedical prevention for HIV, like pre-exposure prophylaxis, became available. And I got very interested in how those tools might be accessible to adolescents, and got engaged with the Adolescent Trials Network. And then that research really raised a lot of questions about minor consent to research, engaging highly marginalized and oppressed adolescents in research, protecting their health, and what the potential benefits and risks of research are, and how we think about those things. And then my most recent project, which is funded by PCORI, I'm using public deliberation to try to resolve ethical conflicts in research and research engagement. As Dana mentioned, I was recently appointed to a National Academies panel on improving representation in clinical trials and research, and I just want to acknowledge that much of my thoughts about this issue today are a product of that work and the amazing work of my colleagues on that report. And this is a link to the full free report. So I kind of thought about this in two different ways, like what are the most critical challenges that I've sort of seen and experienced? If I had to choose three, what would they be? And then how might we address those? So really, I think the biggest problem in research is us, it's researchers, it's our institutions. I think unfortunately we spend a lot of time framing the issues of inclusion and representation in research, sort of framing them in terms of characterizing potential research participants. And you can just look at the language that we use. We use language like vulnerable, mistrustful, hard to reach, minority. I mean, it's like we're already giving ourselves an out to this task before we even start. We're excusing ourselves from the work. So I think one of the most important things is that we stop doing that. So in the report that the Academy panel put together, one thing that really struck me and surprised me so much is a huge problem actually is it really is us. I mean, I'm using the reference from Taylor Swift. I have a 10-year-old, so it's all Taylor Swift all the time in my household. But in all seriousness, it is a really grave concern. One thing that the panel found is that investigator and clinician, because we know clinicians are often a linkage to health research, hold significant bias and assumptions, and it is a really important barrier to engaging folks in research. We have biased thoughts about who's likely to comply, who can understand research, who will be able to do it. And then we also make a lot of assumptions. So there's a really decent body of evidence that Black and African American and Latinx populations are actually no less willing to participate in research. However, we sort of make assumptions about willingness to participate, about mistrust, and we also create structures that really limit their engagement. Another key issue that we identified is just the research structure. I don't imagine this is a surprise to anyone, but I think what is a surprise is the extent to which all of these processes create a barrier. We can work on mistrust, we can think about ways to make research more accessible, but really the academic structure does not honor the level of commitment and time investment that it takes to build the sort of relationships that are meaningful and that address systems level barriers to research. I have my references at the end. I can link you to some of the papers that I'm referring to, but this paper in the Chronicle was just so searing to think about. And there's a database where you can research how many Black women have tenure on your campus. And for IU, it was two people who were tenured Black professors on the campus. And when we think about building trust and we think about, the data that do exist on the relationships between people and what it means for them to see people who look like them and who are from their communities and have lived experiences that are shared. It's not everything, but it is important. And also when we think about the ways in which clinical trials are often co-located with universities, which are difficult to access for rural populations. And I think the rural populations are often a forgotten group that's often excluded from research. And then there are also regulatory barriers. So I just want to say again, these are just three things that I've kind of been thinking about. There are many other barriers. But because I focus so much on consent and other sort of ethical barriers to research, this also really came out and was sort of my contribution to the report. When you think about IRB approval, IRB review, I think that we have been so concerned about the possibility of coercion that we underpay people to be part of our research. And we also are so focused on like making sure that everyone is receives the same remuneration, but that's not always appropriate because some people need help with transportation or childcare or lost wages and other people don't. So we really need to think about the ways that we understand ethics and the ways that we think about the IRB has a responsibility to ensure that the science is right. But part of having the science right is enrolling who you say you're going to enroll and enrolling people who are affected and could benefit from the research. So I think we have to rethink the roles of the IRB and the ways that we interface with our IRB. In terms of actionable steps, I think the biggest thing, like the one thing that I'm really working on for myself and my colleagues, is just really flipping around the way that we think about this. We don't need to reduce mistrust. What we need to do is demonstrate our trustworthiness. And that goes for researchers and for our institutions. I just want to acknowledge the work of Andrea Gilmore-Bukowski and colleagues. They have done an amazing job of really exploring this issue and about changing how we think about mistrust and what it means to really create trust and engage folks. And what that really looks like is having a relationship-centered approach. I would do a disservice to try to, recap their research, but I have, again, in the list of references, this paper. It's open access. Highly encourage folks to take a look at the work of this team. They've really done an amazing job of exploring this in a very thoughtful and rigorous way. But just a couple of things that I think we can do as researchers. We can explore and address our own bias. We can understand the ways that we think about people, the way that we spend time, the way that the assumptions that we might have. One thing that I'm really working on is thinking about the language that I'm using, the language that I use to represent my participants, the way that I frame what they've said, the way that their identities are reflected in publications. And you can evaluate your own lab culture, who gets to be an author, who gets the travel funds, who gets to write the grants and be the PI, and what kind of feedback mechanism do you have for your team and your participants? But more importantly than that, how do you respond to it? In the longer term, we can build those authentic community partnerships. And again, I would refer back to Andrea Gilmore-Bukowski and team. They have lots of papers about this. Gina Green-Harris is another researcher who's published quite a lot on how to have authentic community partnerships. And spoiler alert, it takes a lot of time and a lot of money. And again, academic structures don't incentivize that, but I think we can change that. We can also think about what does it mean to co-produce knowledge and to disseminate that knowledge. What does it look like to engage people in that process? And then our institutions, we need to push our institutions to do a better job. Indiana is not known for, being a bastion of progress, but I have to say that my university has really made a strong effort to rethink the requirements for promotion and tenure. Very quickly, we changed, folks can go up on diversity, equity, and inclusion as an area of research excellence, as an area of excellence. They have tried to remedy the fact that some of our colleagues who've been doing this work for decades were not recognized for it. And many people on our campus have received very quick promotions as a way to try to sort of remediate their marginalization from these processes. Our school is also doing quite a lot to build pathways from undergraduate to terminal degrees in the biomedical sciences, building sort of a gap year, a fifth year for folks to get prepared for graduate school and graduate school applications. We can also push our institutions, our IRBs, to make changes to how they think about equitable compensation and scientific rigor. And this is a link to some references. It's not an exhaustive resource list, but it's a starting point. And I, look forward to the discussion today.
You're on mute.
Deena, you're muted, I think.
So sorry. Shamika, thank you so much, Amy. And Shamika, do you want to go next to just introduce yourself and your work and the way in which you've been thinking about some of these issues related to equitable research practices?
Yes, absolutely. And wonderful job, Amy. Thank you so much. It's an honor to be on this panel with everyone today. Good afternoon. I'm Dr. Shamika Thomas. We've already given a quick intro of who I am, but I'm the Provost Fellow and Research Faculty here at OSU Bioethics. And I'll just like to kind of point out or echo some of the same sentiments, but starting with the research that I do is largely framed around 4 tiers. And the first tier is anti-racism, reproductive health justice. The second is methodological justice and methodological equity. The third one is cultivating diversity as an ethos. And this is bidirectional. So this is not just about who we include in our studies, but how we engage our scientific culture and research, the researchers on our team. So making sure this is a bidirectional ethos of diversity and diverse equity. And the fourth thing that my research focuses on is centering Black women's reproductive health narratives. And this largely gets at the lived experience of race and racism as it intersects with other isms in this nation and throughout the world. So on this CARE panel, I know Deena asked me to speak about inclusive recruitment practices, but I like to add the word cultivating before we kind of talk about that, because this is an exercise of cultivation and a demonstration of what this means. It's always ongoing. We're always trying to be very critical and reflective about our research processes. And so I like to add to that title by calling it Cultivating Inclusive Recruitment Practices. So I have some concrete examples that I'd share before I pass it on to my next co-panelist. But one of them is when I was doing some research out in South Florida on street race and reproductive health, and it gets at colorism at the clinical encounter, we interviewed women where they were. So we didn't just go to clinics and hospitals to recruit, but we also went to women where they were in their homes, at the nail salon and the hair salon, daycare centers, and this provided so much more of a higher response rate, and it just provided so much community engagement and visibility of our research. Another aspect of my research when I was at NIH, we conducted 40 patient cases of Black women with and without sickle cell disease in the nation, and this is one of the first large data sets that solely includes Black women with and without a genetic condition of this magnitude. And one thing I want to point out about that is when it comes to a standardized reference group. So many reviewers were often asking me, why didn't I include white women in the sample study? And I just believe that my own personal rationale and also scientific rationale has to do with white women and Black women are so often compared and contrasted in a way that is very inequitable. And so my work, I largely speak to seeing Black women as their own standardized reference group, and also disentangling how Black women are historically homogenized in these study samples and in clinical trials. So my work gets at the disentanglement process and trying to see the variance within such a beautiful and large group of Black women as it stands within itself. It's enough variance for it to have its own comparison. And lastly, I'll just like to point out, as I do empirical bioethics and including study participants in our data analysis is a part of the process of being inclusive, but also being aware of how we need to oversample on these study populations and how we also need to train our A's and undergraduate and graduate researchers to be a part of the publication process and to, speak to these pipelines, to press in on being much more centered themselves. This gets at humanizing the research process, specifically as this process has been so devaluing and has dehumanized so many different scholars and also study participants along the way. So I like to close out my little section with a quote from Toni Morrison, because when we talk about censoring and we talk about what it means to be in the margins, and I like to say as an African-American woman, scientific scholar who's doing work out on the margins, what does that mean for me? And Toni Morrison, who is an amazing writer of our era and time, who's transitioned, she wrote, "They say you write well enough. You can come to the center if you wanted to. You don't have to stay out on the margins." And I'm saying, yeah, well, I'm going to stay out here in the margins and I'm going to let the center come look for me. And so that just really speaks to how she stayed out in the margins and allowed the center, or what is the discourse of what a center is defined as, to come look for her in the margins. And I'm going to echo the same thing, that the work that I'm doing is about the margins. And if you want to find what we're doing, come to the margins as a center as well. Thank you.
Thank you so much, Shamika. Deena, do you want to also introduce yourself, introduce your work, and how you've been thinking about these issues?
Sure. So I'm Dr. Deena Chisolm. As was mentioned, I'm a professor of pediatrics with joint appointments in public health and nursing. I'm trained as an epidemiologist, health services researcher, which means I am a data person and I am a systems person, more so than I am a bench researcher or anything like that. I work specifically in children and families. And my work really exists at an interface that includes community and social drivers of health, health equity, and health policy, and how those things come together. And I guess what I want to bring to this discussion, and I'm really excited about the broader discussion, I'm sure a bunch of other things will come out. But it's thinking about when we're talking about diversity or inclusion within research, how are we including that discussion at the very earliest point of the study design, the development of the study question? What are we trying to ask? What analyses are we planning to do? I can't tell you the number of times I've seen studies where they're all the way done and they say, well, we want to be able to look at this by race. I'm like, you didn't do anything in your design to allow you to have the power or the right population to be able to do this. This post hoc, and it's not going to be meaningful. So, one of the things is really making sure that we're thinking about what the question is at the very beginning, so that we recruit the correct populations to be able to answer those questions going forward in the research. I think the other thing that a couple of other things that I wanted to put on the table. One, this idea of how do we generate this diversity in our samples. And I have seen a lot of really not great studies where the approach to maximizing the Black population in the study has been to identify the 5 zip codes with the most dense Black population and oversample from those places. So we'll get a bunch of Black people in our sample. But without any discussion about what biases are you building into the Black population that you're including in your study. So that when you turn around and you write your paper and you say, well, the Black population is overwhelmingly poor and urban and blah, blah, blah. No, the population you intentionally sampled has those characteristics. And therefore, you need to think about what you are immediately taking off the table in terms of generalization, what you're putting on the table in terms of bias, and how you're going to mitigate that in the way you write and think about and talk about your populations. I'm part of a big nationwide study whose I won't name, but it's a nationwide study, and they wanted to focus on making sure they had sufficient diversity, but 90% of the African Americans they recruited into the study were at the Atlanta study site, where the white population, other populations were diffused across the country. What bias is there in saying our Black people look like Atlanta and our white people look like the country? Maybe you say there aren't any. Maybe you say there are, and here's what they are. But you got to actually recognize the challenges associated with that kind of a design. Similarly, I've done a fair amount of research in sexual orientation and gender identity, minority populations. And one of the things that I was really excited about when I started doing work in that space was so much of the work on adolescents, particularly who had sexual orientation differences, was done in public sex environments and community sex environments. That's where they recruited most of the youth for these studies. And then they said, this is the experience of teens who are gay, lesbian, bisexual, queer, and put that out there. They're like, that's the experience of the ones who are in those environments. There's a whole bunch of people who aren't in those environments, who don't even know how to get to those environments, who have other issues that would keep them from being in those environments. How do we look at people who are not in those groups? How do we identify people in primary care settings? How do we identify people in schools where we get a group who are on a different place along that spectrum? So thinking about not treating any of our non-white populations as monoliths, and recognizing that however we sample, we have to be able to recognize what the impacts of that sampling design are, and not just say, hey, we got up to 20% of our population in our sample without asking those hard questions. And then the other thing I just want to make sure that we're thinking about is, you know, a lot of this is research where researchers are designing the recruitment model and designing who's getting into the study. A lot of stuff is done using secondary data that already exists. And some of that secondary data has good representation, some of it doesn't. Recognizing that when you choose the database that you use to do that secondary work, if you're part of what you want to be able to talk about is specific subpopulation outcomes or differences, and being thoughtful about when you disaggregate, when you look at differences, gaps, disparities, inequities, whichever term you're using in your work. What are you attributing that to? So to the extent that you're saying we've got racial diversity and Blacks are different than whites, so what and why? And we've done so much research over, I would say, 2 going on 3 decades of showing these differences without asking the so what and the why and the how do we fix it part. And we need to get out of just showing differences in the analyses that we're doing. So I'll stop there and join the discussion.
Thank you so much to all 3 of you. I mean, for first of all, pushing back on the general framing of the way in which we've been thinking about it. So I heard from Amy that, you know, it shouldn't really be about how do we address mistrust, but rather about how to actually exemplify trustworthiness in our research practices. I heard from Shamika that it's not just about the practices as this like abstract thing, but it's about our own cultivation process and like, how do we actually think about this and our relationship to these things as an ongoing thing. And from Deena, I heard that even focusing on like equitable recruitment and enrollment is already too far in the life cycle of the research project. And we have to think really more holistically about what research questions we're asking, what are the priorities of that research, and who we're just like even speaking to when we're asking these questions. And I just really appreciate all of that pushback, because I think that it really highlights the way in which, when you think about recruitment in particular, it's just part of this much bigger discussion and process. And I just really appreciate that. So first question is about recruitment. And I think then we could sort of get a little bit more sort of generalized from there. And I see there's already one amazing question from the audience. This is just an invitation for audience members to also continue to asking questions. We'll definitely have time for that. So this is just a question about what, in your view, are the most important steps that researchers can take to make sure that they're proactively promoting equitable recruitment and enrollment practices. What steps have you taken or have you seen taken that have really worked? We've heard a little bit of, you know, where to actually go to recruit, but what has worked? And is there anything that you've seen from well-intentioned researchers that hasn't worked, has potentially backfired? Maybe we'll start with Amy, and then anyone else who wants to respond can go after that.
Sure. I think for me, one of the most important shifts was, well, a couple of things. One is providing higher incentives than probably is typical, providing more money, and when I can, I try to provide it in cash. A lot of universities won't do that, and a lot of my research sites aren't able, but where I can do that, I do. It's just, you know, most people want cash. It's better than, you know, sort of like giving them a finite, you know, this is a Amazon or whatever, you know, is feasible for a university. But also with all of my students, I have encouraged them to pay people more. I think the other thing that has been very successful for me, I saw a huge difference when I hired a person who had lived experience that was shared with the people I was trying to recruit. That made a massive difference in terms of retention. I mean, I can point to it statistically. It was an absolute change in not only the people who enrolled in the study, but their retention in the study. And so that was honestly the most impactful thing that I have done in my career. And I've also worked really hard to engage, especially because a lot of my research, I was trying to enroll minor adolescents, queer identified adolescents, and I'm a middle-aged white lady, like I'm not the most compelling recruiter, for folks. And it has been very helpful to have people on my team who are younger and, who are more connected to some of the social spaces that the participants are part of, and just know how to communicate with them in the way that makes sense for people who are in their teens and 20s, which is not something that I know or, think I could even learn, I'm just not gonna do that well. But it was just a massive difference. So.
Thank you. Deena, do you want to go next, and then Shamika, if you have any examples?
Sure. I think all of those are excellent things that would have been on my list, so I don't have to repeat any of them. I think it's really important that when you're developing your recruitment materials, you develop those in collaboration with the communities that you're attempting to recruit from. We had a situation, and you think it's like a little thing. I'm at Nationwide Children's Hospital. We have a brand standard that all our flyers have black and white pictures of. I don't know who decided that that was our brand, was black and white pictures, but it is. And we made flyers with these black and white pictures of Black families for a study we were looking at on reproductive health experiences in the Linden community. And we got a couple of people from the community saying, why are these pictures ugly? I mean, why can't we have nice things basically in our spaces? And, we had to go back to our leadership and say, this isn't resonating in the community that we're trying to work with. And they're like, yeah, but this is the standard. I'm like, I don't care about your standard. We're talking about the standard of the people we're trying to engage. And it took a little bit of, back and forth before they said, fine, you can have a color picture. But, even little things that you don't think are going to turn people off and that you may not even know was the thing that turned people off make a difference. And that's why it's important to really engage the population in that recruitment. What are the media sources that are meaningful and trusted by the people who you're recruiting? If you are going to co-opt or work with a partner, is it truly a trusted partner? And how do you build their trust with you as they're building their trust with the community, so that everybody is able to maintain their independence and trustworthiness independently? So those are a couple of things that come to mind.
Yes, and just to echo the same sentiments here, I just also would like to mention that when it comes to recruitment, centering the lived experience, but also the imagery is a big deal. I would say when we were out in Ghana, we actually had our sickle cell patients living with sickle cell disease design our flyers, design our logo, design our t-shirts. So instead of wearing lab coats and scrubs to collect data, we actually designed t-shirts, by the patients, and we wore those on our clinical days. We actually did a lot of our health screenings and health checkups outdoors, so we built like community spaces under a tent. We had music, so we built it into the fabric of our recruitment design. And then also when we were doing our data collection and data analysis, we invited a random sample of the study participants back to our site to go over the transcripts, the de-identified transcripts. Let us know what you see. Is this correct? Is this incorrect? How do you see the themes emerging? And we actually trained some of them to look at some of the in vivo software as well. So these are just very small, very powerful tools and mechanisms to empower the research process and the study design process that we use on a global platform. And here in the States, this is just really amplified for me to just pay more attention to listen, not just to our study design, but listen to the data, listen to our study participants, operate from more of a, I would say, a circular platform rather than a higher hierarchy, allowing some of the RAs on our team to actually give some critical feedback and thoughts about the investigation, and not just disseminating work and making people informants because they look like the study population, but actually, giving them something tangible to add to their CVs, a certification, skills, research skill set, some hours, something that can help move them forward in the pipeline as well, in the academy and outside of it. So those are just a few tools that I picked up along the way conducting research at NIH, and then also, of course, in Ghana.
So that's, yes.
Oh, I just wanted to follow on that. A couple of things, this reminded me of a comment that we got when we were, sort of presenting some different ideas for recruitment materials at one of our research sites that was entirely Black or African American patient population. And some of the feedback was, everybody in these images is very light skinned, and, that like the colorism, that was a factor for folks. And it was such a good opportunity, I think, to learn. And one of the things that I think, as a white woman, I really had to unlearn the defensive response. And I think that it's so important that we understand as researchers, how to respond to feedback and to say, thank you so much for investing in me and telling me this, and, taking the time to point it out to me, and I'll do better next time. And I think that that's a response I try to keep in my pocket, because it can be easy to be like, well, these are the only images available, or you know what I mean? Like, you can react really strongly to something, and then what you've done is somebody you've not recognized is somebody else is taking a chance to give you information that you didn't have, and you've just push it back to them, or you've like shut down the conversation. And, I've had interactions with students, in my class, and I think this is important for all of us, as in our teaching roles too, who, have brought to me a concern, something in the classroom that didn't sit well with them. And, I think that, again, when you think about like the feedback that you get, it's so important to use it and to demonstrate how you have used it. Because otherwise, okay, you can be receptive, but this young woman came to me and said, the way you talked about substance use disorder, that isn't how my community was treated when it was our issue, and, during the war on drugs, and you've left all that out, and I said, you're completely right. I have, and then I did, but I didn't stop there. And I'm not trying to say I do this perfectly in any way, but it's something that I think is so important, and we're not trained as researchers to then like go back to the student and say, here's the change that I made, based on your feedback. And that's what we have to do as researchers, is like, not just take the feedback, but we also have to say what we've done with it, because I think that that's the only way that you start to really build trust, in your process. And that's the only way to be authentic, honestly, is to take the feedback and to do something with it.
That's really helpful. I mean, it goes back to this point that Shamika made about cultivation, and how we should just not expect perfection, but rather it is this sort of ongoing process that in itself, the way in which we respond to potential missteps actually is an opportunity to build trust, right? And so maybe sort of going to Shamika next, sort of building off of some of the points that you were making related to the novel ways in which you were really trying to bring in community into like the whole process. Clearly engagement with community partners is understood. It's often understood as a cornerstone of developing an equitable recruiting strategy. And how can community partners be an important resource? How can these partnerships be cultivated in a way that is reciprocal? And you've already sort of talked about that, but maybe just sort of really thinking more explicitly about that. And are there some potential pitfalls that researchers should look at for when engaging with community partners?
Absolutely. These are such lovely questions. The first thing is, when we talk about trustworthiness, yes, I wholeheartedly agree, but I think there's a prerequisite to that. And one of the prerequisites to that, and I wrote about this in the Hastings Center report, is being honest about patient blame. So if we're going to cultivate trustworthiness, we need to be honest about how we're blaming patients and how this is hegemonic and historical. And then we also need to be honest about stigmatization and stereotypes. And so these types of things are built into the fabric and the structure of the medical system. And it's so pervasive that it's not, we can't just jump to just trustworthiness. We have to talk about the ways in which certain populations have been historically blamed for their so-called individual health behaviors when they're making these health behaviors in constrained social contexts. And I specifically work with, Black women in reproductive health care. And so a lot of my work sometimes might make people feel uncomfortable, but that's okay because I'm not here to make people feel, especially people in the scientific enterprise, feel comfortable. This work is not pretty. But the thing is, when studying Black populations, I'm not necessarily interested in comparing them to standardized reference groups, such as white groups right away, but I'm interested in disentangling how Black women are often seen as monolithic categories, and there's so much variance within group. So sickle cell disease, how we are perceiving different types of genetic conditions, postpartum depression, C-section rates, looking at breast cancer, looking at different types of, anemia. So just really looking at the different types of intersectional experiences that Black women face and starting there. Another point I would like to bring out is that we need to largely decolonialize a lot of the global health research that has been conducted. We're operating in spaces and using frameworks and standardized studies or discursive studies that have been largely rooted in, just racist ideologies. And so we need to kind of build in ways that we can operate from more anti-racism or, anti-racist practice in our work. And this starts with getting at, like, again, how we mentioned the study design, but also how we're looking at, this biodirectional between how we work with the study participants, but also how we're being introspective about the research groups and the research teams that we're building ourselves. So those are just some quick points, but I'd just like to say that some of the strengths from my research, we have cultivated pretty high response rates during the COVID-19 pandemic. This is very important when it comes to mental health. A lot of the patients that we were working with, they were kind of locked out of the systems of birthing and the clinical encounter. They couldn't bring their relatives with them during their birthing experiences. This spiked in mental health cases for Black women at postpartum depression. And so when we started talking to women, we started noticing that women had a lot to say, particularly Black women had a lot to say. So I started asking not just what happened at the clinical encounter, but how do you feel about what happened at the clinical encounter? And I noticed those two different questions yielded two different responses. And so as I was interrogating the data during in vivo, I noticed we need to tap more into how women are perceiving what happened at the clinical encounter and how we can kind of make this much more concrete. And I guess the last point would be the research to practice divide. The research to practice gap is so large, and it could be very exhausting for early career scholars and mid-career scholars. We're doing this work on the front lines of our soul. A lot of us are suffering from vicarious trauma doing this work. But a lot of this, we have to be much more intentional about interrogating our own wellness, including our own wellness in these spaces, and then also being much more critical as to how, we're closing the gap between research and practice. A lot of our patients really want community engagement now more than ever. And community engagement has been centering wellness practices, self-care, having some of the patients come back just for wellness chats, wellness visits, chair yoga, checking in on your families. How are you? How's baby? How's the family? Just those simple questions of humanity. Those simple questions promote so much wellness in the community, especially for communities that are systemically locked out of these experiences. So I would just like to kind of pause there, but that's just what's coming to my mind right now.
Thank you. And Deena, I'm just going to add, so this is our first question from the audience that is sort of building on this. So when asking, and you already mentioned this, sort of wellness can actually, the experience of research can actually give back to the community. But so throwing it to you, Deena, just how to think about community engagement as a resource. And when asking the community to engage with how we design our work, how can we make sure we are giving as well as taking? I love that framing.
So I'll answer both of those. Starting out with sort of a couple of thoughts on community engagement broadly. Two things I want to mention. Well, maybe one or two things. Anyway, one, when you're thinking about engaging community institutions, you need to be thoughtful about, is every institution in a community institution? The reality is that there are organizations who purport to represent the community that they're seated in, but they really don't. And you have to figure out what is the authenticity about the relationship between that entity and that community, because it's not always as real as one would believe it to be. And we also have to interrogate our own comfort zone. So for those of us who have lived experience growing up in urban low-income areas, we're comfortable walking into the hole-in-the-wall barbershop or some of these other places, where some who are not as comfortable are going to say, well, let me go to this nice big shiny church over here instead of the little church on the corner, because those are the people who, well, they have a nice big tiny church, so they must have a lot to give. But they may not be the ones who are most invested in the people on the street. And so thinking about when you're building these partnerships, don't just go to the things you've heard somebody else went to, or the, big system level partners. Figure out how to get deeper into the actual community partnerships, the local businesses, the local restaurants, those sorts of groups that may be more close to the population you're trying to get to, not more close to you. And I think that is the challenge for a lot of researchers, is they go to the people who they have the least social distance from, even when they're working in populations where they have a lot of social distance. The other thing, in terms of both community engagement and the question, it's really important that as researchers working in specific communities, that you become a part of that community in a way that matters. So, our team, we're doing some work in Linden looking at the history of structural racism and how that's related to reproductive health and birth outcomes over time in that community. And we're doing a lot of recruiting for qualitative interviews. But, sometimes we show up in the community not recruiting for interviews. We just show up to support, show up to volunteer, show up to engage in a way that is not, we want you to give us something, in a way that we are here and being part of what you're doing, or showing up with food at an event, or showing up with an investment in a event that's happening in the community, figuring out how do you become a partner, a true partner, and a party with the population that you're working with, such that they see value in having a relationship with you, and that they believe that you see value in them other than a data source. That is the ultimate challenge, the ultimate goal, and it's where a lot of times we don't succeed.
Thank you. Amy, do you have any additional thoughts on community engagement?
I think that a lot of the points that I would have said were just made, especially the latter point about, showing up when you're not asking for something and just being present and volunteering. And, I think also that gives us a chance to see what communities are doing well, where we're not just like coming in to talk about a problem, but we get to see the strengths and what is going well. And I think we all want to demonstrate what we do well. I think the other thing that really has emerged for me, and it's something that my colleagues and I are sort of tooling around with, how we would bring this to regulatory institutions, but the idea of the social benefits of research participation. Particularly, again, I work with minors who often are marginalized from their family of origin. And one of the things that has come up a lot in my research is the benefits of research participation are not always improved health or in these cases, access to PrEP or other, resources that folks might not have access to, particularly minors. But when I re-interviewed some participants in the first PrEP trial that included adolescents, and I asked them after the fact, about risks or harms or things they wish they'd known, or did they have decision regret, I was so surprised that when I asked them, did you benefit in any way? They were like, oh my gosh, I learned so much about myself. And it was like I had a family, but only a family that really cared about me and really accepted me and loved me and welcomed me. And that was really moving. But I think the next layer is, what do we then owe? If we're building these therapeutic relationships with folks, particularly if they're in a long trial like these young people, and they feel cared for and they feel welcomed, when you think about other therapeutic relationships, you have to have closure, you have to plan for it, you have to do it right. And I don't know that we always do that especially in clinical trials, but I think it behooves us to recognize the value that our participants see in being part of research, especially a lot of minors. Like, they felt so good about being able to do something for their community and for the future, and they thought it was so important to them. And also they got these social benefits that then when the trial is over, those benefits are gone. So how do we plan for study termination? How do we close a therapeutic relationship that wasn't really part of kind of the planned benefit of the study is something I've been thinking quite a lot about. And I think the same is true in community partnerships. Is your relationship over when the grant is over, or do you continue to show up? And what does that look like? And, we all have limits, right, on our time and our capacity. So how do we do these things well, while still protecting ourselves as we do the work, I think is a big question in my mind.
Thank you. So, Shamika, yeah.
Yes, I have a quick point about that. So a part of our research budget, once the study was done, the data collection was done, I just sat with my team and we tried to brainstorm, how can we bring some resources to our study patients? And so I used a big chunk of our study budget to gather menstruation pads, tampons. We did a clothing drive, clothing donation. We had a whole, research, data analysis, celebration, health workshop. And so it was really beautiful. And we just brought out some, media. We had the study participants sign forms if they were comfortable being a part of that process. But it was just really good to give back in that way. And then we also had some of our patients do arts. So some of them wrote poetry, they did songs, they made bracelets. This is actually a bracelet that was made by one of the young girls. She's 13 years old with sickle cell disease, and she makes bracelets to support her family. Her and her mother have a little bracelet business. So these are just ways that my team and we try to pull together to also see the need, but also see the strength of the community, not just coming in as a savior, but also bringing people together to just kind of support what's already going on and to partner in that way.
Thank you. So let me jump in to ask some questions from the audience. One question is about, so this HPV vaccine was originally covered. So there was this finding that HPV vaccine originally covered the 3 most common strains of HPV in women. However, it was later determined that those 3 strains were not the most common, were just the most common in white women. So what measures and practices, I will add, should there be in place to ensure a patient pool is diverse enough to catch these sorts of findings? And maybe we'll start with Deena, since you are the data person. If you have some ideas about how to think about, diversity within the sort of enrollment population, and the downstream clinical effects of the research.
Sure. I find this really interesting because this morning I was at a chemotherapy visit with a very good friend. And while she was in the exam room, a research assistant came in to ask her about participating in a study at the James. And it was basically a biobank where they wanted to access her medical records and her samples across her treatment and link those and de-identify them and put them somewhere in the cloud for researchers to be able to answer really interesting questions. And you need those really big databases with really diverse populations to be able to identify differences at the subpopulation level. You got to get lots and lots of people. You got to get multiple sites, and you got to have active recruitment. She said, so what percentage of the people in this database are non-white? And the RA said, I don't know, but that's a good question. I will find out and I will get that answer to you. So A, good answer. B, might be a nice piece of information to have on hand. But to recognize that part of our message, particularly when we're doing things about, these large data sets, biobanks, that sort of thing, is that you're not going to get value yourself, but you're allowing your population, the people that look like you, your daughters, to be represented in these databases. And that's what we have to do to be able to get those numbers to where they need to be. But we also have to put all the right guardrails around the use of such data, because one person runs a study that misrepresents the data or villainizes or demonizes the people whose data are in there from different populations, you shut down your entire stream of participants. So you have to be very thoughtful about who you're letting do work in your biobank and what the IRB process is for getting access to those samples, and how clear do you have to be about the way you're going to treat every population that's represented in that data, because it only takes one slip up to really injure your ability to collect that data. So the answer is we need lots and lots of data. We need lots and lots of diversity within that data, and we need to collect it in a way that is sensitive enough to keep people wanting to do this work.
Amy or Shamika, do you have any other thoughts? So let me jump in and ask another question. So this is from Joseph Naguta, who is actually streaming from Kenya. So thanks, Joseph, for joining. So Joseph asks, how do you ensure equity and equality while recruiting subjects across different ethnic groups, white Americans versus Black Americans? And one of the things that I think Shamika brought up that is really interesting is sort of who the standardized reference group is. And so also thinking about, I invite you to just also maybe think about equity within specific demographic groups. How should we think about those sorts of issues? Yeah, Shamika, why don't you start?
Yes, such a really good question. And yes, shout out to Kenya. I am so I'm very, very, or at least I try to be, or aim to be very intentional and specific about working with single populations that have so much texture. And I'm a qualitative analyst, and I work in mixed methods as well. So I really try my best to be very broad, but then also very specific. And so a concrete example of this is working with sickle cell populations. So we actually published a paper where we discovered that when it comes to patient perceptions of non-invasive prenatal testing and the genetic technology, that a genetic condition was not seen as a social demographic. So among those patient perceptions, Black women with sickle cell were typically left out. And so we discovered that in order for to have a wide variety of patients and their perceptions on these genetic technologies and gene therapies and gene trials, we need to also include patients with genetic conditions. And so my point here is that, seeing the genetic condition or a lived experience of a genetic condition as a part of the social demographic. That's just one point from speaking from my research, but also being much more broad in the sense that when we send out recruitment materials, we send it to maybe NGOs or community partners, but also word of mouth, people in the community passing it, around, not just gathering samples from people that have the same type of intersections, that may or may not go to church, that may or may not go to this local hair salon or nail salon, that may or may not live in this particular region. So being very thoughtful about the multiple different intersections at play within a single racial group. And I'm not necessarily someone who includes, let's say white women in my study, so I can't speak there. But what I can say is I have worked with Afro-Latinas, also Caribbean populations with African ancestry. We also look at populations who self-report as Black or have mixed identities, or may self-report as Hispanic, but also have a lived experience of Black when you visibly look at them. So different variations and varieties and textures of what it means to self-report and self-identify as a Black person in the United States is one of the ways that I've been trying to be very sensitive to recruitment.
The other thing I would,
co-presenters might have something else to add.
so the other thing I would add, particularly around this question of equity and equality, is making sure, and I said this in my sort of opening statement, that your subgroup analyses, if you're doing subgroup analyses, are broadly represented. So much of the research that I see basically says we are using race as a proxy for socioeconomic status. And if they don't say it, they infer it from the way they use the data. And ultimately that suggests that only Black people are poor. And I live in Ohio. I know there are a whole heck of a lot of poor white people who are experiencing the issues of poverty, which are separate from the issues of race and racism. And we can't just put them in a bucket together and say that's one thing. Shamika can tell you as much as I can. When you look at something like maternal mortality, wealth is not a protective factor in the way you might think it is. I've worked with faculty that, well, if we just get everybody educated, then we won't have this racial disparity. And then I say, Black women with a college degree have infant mortality rates equal to white women who didn't finish high school. So let's talk about the fact that that's not going to fix. So thinking when we're talking about equity and equality, thinking about the intersectionalities and thinking about the fact that we do everyone a justice when we don't recognize the off diagonal, if you want to call it that, whether that's the rich Black person or the low income white person. They matter too, and they need to be represented for us to truly equitably reflect the health of the community.
Amy, do you have any thoughts related to just sort of, within certain demographic populations, how to think about equity?
I don't have anything above and beyond what my colleagues have already said. So
Sounds good.
I don't need to be redundant.
No, I mean, there's like so much good stuff. I'm gonna have to like rewatch it and just like in like 0.75 slow motion.
Yeah.
Take notes. So one question sort of to close out our discussion is about sort of structural barriers to these challenges. So thinking a little bit more widely, are there policies, institutional policies or regulatory structures that either enhance or pose barriers to equitable representation in research? And what opportunities do you see in potentially changing any structural barriers? So maybe I'll start with you, Amy, and then we'll go to Shamika and then Deena.
Sure. So again, I would point back to the National Academies panel. I mean, the recommendations are extensive, and they include a lot on the research enterprise, sort of start to finish, like what are these structural barriers within academia, particularly, but also non-academic research settings. I do think, at IU, my experience has been amazing because the IRB has been great and very flexible and very willing to like have a conversation and dialogue about how to approach things, which has really made a lot of my own research possible. But I think in terms of institutional changes, I mean, even just some of the things that I mentioned around, changing how we sort of academic products that we consider successful, and what we consider to be productive, changing some of those metrics, changing, as I said, like IU created an entire area of excellence. So it's no longer research, teaching, and service, it's DEI and meaningful DEI, I should say. There are metrics for measuring it, metrics for rigor. And people have been able, like one of my friends was able to go up for full professor only a year and a half after she made associate, because so much of her work was focused on these efforts. And so I think that those are institutional level changes that we can make, and being part of or participating in some of these pipeline programs where we do get to mentor and sort of facilitate the growth of people who've largely been excluded, honestly, from academic life. And making sure that who we hire as researchers, when we are lucky to have funding for hiring, that we pay attention and we don't just do the friends and family model where it's like, oh, I know you had that great research assistant, like what was their name? That we really are being thoughtful and mindful about who we hire, and thinking carefully about those processes, I think.
Yes, definitely powerful. And to echo the same sentiments, thinking about structural barriers, one that comes to mind definitely is funding. Grant funding mechanisms, how we fund, and why we fund, who we fund, and how is it allocated. I know in particular maternal and child health, there's been a spike in it, but there's so many researchers who've been doing this work for so long, and now people are just popping in on the bandwagon of the trend, and just because they tack on race and tack on maternal and child health, they get funding because of their privileged statuses. And when people who have been historically doing this work for 5+ years, 10 years, I've been doing health equity work for some time now myself. So just really being thoughtful about how we measure who gets this type of funding. And then second is prioritizing social justice as a part of these mechanisms. So LC related work, looking at more of the ethical, legal, and social implications type work. And it must be institutional priority, so that funders can really see this as a value add to the communities, but also to the scientific industry. So, and then the last thing is also recognizing, redefining, and broadening who we give this scientific innovation to, the credit to. There's so many scholars that have been denied a lot of this work, who have been on the front lines of this research historically. I'm just thinking of names like Henrietta Lacks. I'm thinking of scholars like W.E.B. Du Bois. I'm thinking of scholars like who Alden Morris wrote the book Scholar Denied. I mean, these are just some ways in which to make the scientific enterprise much more attractive to early career scholars, and much more attractive to undergrad and graduate students who are interested in research, but it has not been very alluring for them because it's been very discrediting to a lot of our populations, much more broadly. So I think those are like the top 3 that's standing out to me right now, and we just need to be much more critical and sensitive about.
Could I add one quick thing that I failed to mention, but I think just to tag on to what you're saying, Shamika, like the work that has been done, and one of the most powerful things, Dr. Consuelo Wilkins gave a talk here at IU, and she said most of you are never going to do health equity research, if any of you. Like, people have been doing health equity research and they're doing it well, and you need to, you can help advance health equity, but you're probably not doing health equity research. And if you claim that you are, you're probably doing a disservice. And so one of the papers that I had linked into my reference list is by Elle Lett, and it really talks about the thing that you were just referring to, Shamika, around sort of co-opting the work that has been done and done thoughtfully. So it was a really important read for me, and I hope folks will take a look at Dr. Lett's work, because I think it really sort of drives on to that point that there have been people who've been doing this and haven't been recognized, haven't gotten the funding, and now other people are swooping in and taking up that money now that there's an interest in it.
Yeah, I love Elle. She was great. I've had a chance to chat with her at a couple of conferences. I guess I'll take, one big step I don't know, up or back or something and talk about the elephant in the room, which is the current political environment in the state and the nation. There are going to be barriers that keep popping up as people become more concerned about the political repercussions of telling the truth, about the political repercussions of generating the information that proves facts that people don't want to hear. And to the extent that people who are in state-funded institutions are subject to those political wins, there's a risk of pushback and a risk of losing a lot of the forward progress that's been made over the past decade or so that has generated the pushback. So I think that, structurally, there will probably be new headwinds. And we as researchers will have to find our ways to work under, around, and through them to continue to do the work that needs to be done. And that's challenging, and it is wearing on people who've been laboring in this field for a long time. But at the same time, we know it must continue to be done. And that's why you can't not watch the political landscape at the same time you're doing really great analyses of really exciting data, because they come together as one when we're trying to make a difference in the health of, in my case, children and families, and in the cases of everybody else's research work.
That was beautifully said, Deena. Thank you.
Unfortunately, we are out of time, but I think that that is actually the best way to end both a daunting task, but also empowering message. So I just want to also highlight, we don't have time for this, but one anonymous attendee in the Q&A put a comment just thinking really proactively about the ways in which IRBs can actually support some of this work for researchers. And I just want to give a shout out to the participants that are listening in. It's just, you're always thinking about all these sort of careful, proactive measures. And I'm grateful for Deena and Shamika and Amy for really sort of framing these sorts of conversations. And I look forward to continuing them at Ohio State. So thank you, everybody.
Yes, and thank you too so much for bringing us all together and cultivating this process for us. Thank you.
Yeah. Thank you.
All right, bye-bye.